Voilà, on va poursuivre. I have the pleasure to introduce Eamonn Delahunt. It's the second time in Switzerland. We appreciate and we are happy to have you here. Eamonn is a professor in University of Dublin, but is a co-chairman or co-chair from this famous ankle consortium. He's a god of the ankle in the world. And he published a lot of papers, 120, more 120. Dear Eamonn, thank you again, and the stage is yours.
Nicholas, thank you for the very nice introduction. It's really, really great to be here. And Mario, special thank you for our interactions over the last number of months and the generous invitation. As Nicholas said, it's the second time that I've attended this conference, so I was here 2 years ago. So it's a great pleasure to be back and to interact with some nice, friendly faces. But I'm going to get down to business straight away. So let's consider the scenario where any of you from the audience have just been appointed as the lead physiotherapist to a high-profile, well-resourced high school basketball team. But during a pre-season conversation with the head coach, the topic of conversation is dominated by the head coach's perception that injuries in the previous season had a negative impact on his team performance. And ultimately, the conversation ends with the head coach asking you the question, how do you keep my players on the court? So I believe that a thorough understanding of injury epidemiology can provide clinicians with information that can assist them in determining whether a healthcare intervention can really increase the likelihood of a positive outcome. And with this information, it's possible to determine the expected number of injuries per team per season. It's possible to interpret the credibility of reported outcome metrics in published peer-reviewed articles, and it's also possible to evaluate the external validity of exercise-based injury prevention programs. So let's take point one. How do you determine the expected number of injuries that you, this physiotherapist of this high school basketball team, is going to have to deal with on a season basis? So these are data sourced from the US High School RIO database, the Reporting Injuries Online database. And along the y-axis, I have ankle sprain injury incidence rates, and that's quantified as the number of injuries per 1,000 athlete exposures. And what we can see in boys is that the ankle sprain injury incidence over a typical basketball season is 0.69 injuries per 1,000 athlete exposures. And the injury incidence rate for girls is a little bit lower at 0.55 injuries per 1,000 athlete exposures. So how can we use this information then to calculate how many ankle sprains that you, that physiotherapist of that high school basketball team, are going to have to deal with on a season basis? Well, if we think about athletic exposure attributable to competition, and we also have athletic exposures attributable to training, well, over a high school basketball season, there may be as many as 28 matches. There's a maximum number of 12 players on the bench. Okay, so the maximum number of athlete exposures attributable to competition is 12 players participating in 28 matches. So that gives us an athletic exposure of 336. If we move on and have a look at the practice. So typically on a high school basketball roster, you'll have 15 players practicing. They may practice as many as 5 times per week, and the typical season is 14 weeks. So in order to get the exposure associated with practice, we multiply the 15 players practicing 5 times per week over 14 weeks. That gives us 1,050 athlete exposures. So the total number of athlete exposures potentially for this high school basketball team is around 1,400. Now if we go back and we look at the ankle sprain injury incidence rate for the boys, 0.69 injuries per 1,000 athlete exposures, and the injury incidence rate for girls, 0.55, that actually leads to just 1 ankle sprain per team per season. which we may think is quite low, and indeed it is. But it's important information for us to be able to utilize in order to determine whether an exercise-based injury prevention program is credible and whether it has any external validity. So let's move on to point 2. How do you interpret the credibility of reported outcome metrics in randomized controlled trials? So we're thinking about exercise-based ankle sprain injury prevention programs. So because you, the physiotherapist, have an interest in evidence-informed medicine or evidence-informed practice, you decide to do a PubMed search. So you put in ankle and basketball and prevention. And what you're interested in is only randomized controlled trials, so you're going to filter to randomized controlled trials. Okay? And what we get is 113 studies that you are going to actually have to filter using title and abstract screening. And after that title and abstract screening, you identify these potential randomized controlled trials that you might read to determine whether you're going to use that to influence your clinical practice. So the first one was published in 2006 in American Journal of Sports Medicine, then 2007 in Clinical Journal of Sports Medicine, and so forth. So these are 5 interesting, contextually specific randomized controlled trials looking at ankle sprain injury prevention programs, and you want to determine whether these can be used to inform your clinical practices going forward. So if anybody doesn't know what jiggery-pokery means, it means a bit of nefarious behavior, okay? A little bit of malpractice. So the question is, can a healthcare intervention appear to increase the likelihood of a positive outcome without actually making a difference? So understanding whether a healthcare intervention can really increase the likelihood of a positive outcome is essential for translating research into clinical practice. And what we persistently see in the published literature is the selective reporting of injury risk outcome metrics. And this selective reporting of injury risk outcome metrics can actually mislead clinicians, you, the readers of research, into thinking that an exercise-based intervention is actually more valuable than it really is. So when it comes to reading literature, there are a number of injury risk outcome metrics that you need to be aware of, and you also need to how to calculate these, how to interpret these, and how to utilize these to inform your clinical practices going forward. So the first one is the injury risk in the intervention group. The second one is the injury risk in the control group. We then have RR, which is the relative risk. We have RRR, relative risk reduction. We have AAR, which is the absolute risk reduction. And then we have possibly the most important thing of all, the numbers needed to treat. So if we take an example here, there were 100 individuals randomized to the intervention group. Of those 100 individuals, 10 sustained an ankle sprain injury. So we have a risk of ankle sprain in the intervention group of 10%. Let's take the scenario where, again, there was 100 individuals randomized to the control group, 20 sustained an ankle sprain injury, so the risk in the control group is 20%. What we can then do is we can calculate the other risk metrics. So the relative risk, a relative risk of 1 means that there's an equal risk of sustaining an injury irrespective of whether you're in the intervention group or the control group. So what we can see here is the relative risk in this hypothetical scenario was 0.5. So what we would say is individuals randomized to the intervention group had 0.5 times the risk of individuals randomized to the control group. Okay, so the relative risk reduction is 50%. And if you only concentrate on relative risk reduction, you're going to be misled. It doesn't tell the true story. What is actually more important is the absolute risk reduction. So the absolute risk reduction is the control group risk minus the intervention group risk, and in this situation, it's only 10%. So much less than this impressive 50% statistic. Okay? What we can do then is use the numbers needed, or we can calculate the numbers needed to treat is 1 divided by the absolute risk reduction, which in this instance would be 10. So what that means is 10 individuals would have to be exposed to the full intervention in order to prevent a single ankle sprain injury. So let's look at this table here. Everything highlighted in green was what was reported by the authors of these studies. Everything else is what I actually calculated from the data published in the studies. So what we see here is potentially false statements. Look at this. Compared with the control athletes, interventional athletes had a 66% reduction in non-contact ankle sprain injuries. That is actually incorrect. Okay? And the risk of sustaining an ankle sprain was reduced by 35%. Again, incorrect. If you focus on relative risk reduction, we need to focus on absolute risk reduction and numbers needed to treat. So when I look at those 5 studies, the average absolute risk reduction across those 5 studies was 4%, meaning that if you had 100 individuals and you exposed them to the full interventions in these scenarios, you're only going to be able to prevent 4 ankle sprains. Okay, so not that impressive. If we look at the numbers needed to treat across these 5 ankle sprain injury prevention programs, okay, the roster size of that high school basketball team is 15. Okay, numbers needed to treat here is 26, so 1.7 times the roster size. So if you expose your group of athletes to this exercise-based ankle sprain injury prevention program, you mightn't actually prevent 1 single ankle sprain. Same scenario for study 2. Numbers needed to treat of 19, 1.3 times the roster size. Study 4, 77, 5.1 times the roster size. So when it comes to evaluating whether you would implement that study, absolutely not. 22, 1.4 times the roster size. This study here might be of interest to us, 7, so 0.4 times the roster size. But actually what's potentially more interesting is then how do we evaluate the external validity of these exercise-based ankle sprain injury prevention programs? And the question is, are they actually a return on your time invested? And this is something that you really need to consider. So what I've plotted here along the y-axis is the time required to prevent a single ankle sprain. And I've defined that by multiplying the individual player exposure. So for 1 player in your squad, how many hours does he or she need to undertake this intervention in order to prevent 1 single injury? Okay, and then we multiply that by the numbers needed to treat. Okay, and that gives us the time in days of the exposure. But we know that the average time loss for a single ankle sprain is around 7 days. Okay, so what we see is that the actual time to prevent a single ankle sprain in all of these 3 scenarios far exceeds the time loss associated with a single ankle sprain. So that goes back to the situation. Are these externally validated programs? And then that brings up in my mind is, well, what are the composition of these programs, and do we need to be thinking in an alternative way? So what I want to do is present to you the sensory motor system. And if anybody is interested in understanding the fundamentals of the sensory motor system, I would definitely recommend you read this seminal article by Ryman and Leppard, published in Journal of Athletic Training back in 2002. It's open access and it's a classic article. I saw Dustin nodding his approval there, so that's good. So what we have is the organization of the somatosensory system. So afferent information is integrated at a number of different levels. It's integrated at spinal cord level, it's integrated at cerebellar level, and it's integrated at cortical level. Okay? So when we think about the sensory motor system, and particularly the spinal level of motor control, what we need to do is construct exercises that incorporate the afferent processes and subsequent efferent outputs. But just to give you a definition of the sensory motor system, it incorporates all the afferent, efferent, and processing components involved in maintaining functional joint stability. So if we move on, the safe execution or the safe performance of motor tasks is really dependent upon the synchronous interaction of pre-programmed sensory motor efferents and afferent feedback processes. So disturbance of this synchrony, as may occur following a joint injury, has the capacity to distort the pre-programmed specific motor coordination strategies stored by the central nervous system. And effectively what we say is that injury corrupts the sensory motor accuracy of lower limb motor control during the performance of motor tasks. And this is a nice pictorial representation of how that might occur. So from Caperli and colleagues in 2006, if we think about a rupture or a ligament injury to the anterior talofibular ligament, well, we're going to get mechanical instability, and we can assess that mechanical instability through the performance of the anterior drawer test. And we may find a positive sulcus sign indicating that that ligament is completely ruptured. Well, what happens is there's excessive movement. We develop pathological laxity. That changes the afferent feedback into the central nervous system. We get central nervous system reorganization, and that has a consequential effect on reflex activation and then pre-programmed task-specific motor coordination strategy. So we get this process of altered motor control. Similarly, disruption of the mechanoreceptors. So if I move on to this diagram here, again, we have cutaneous structures. We have articular mechanoreceptors, and we have musculotendinous mechanoreceptors. And there is evidence to show that following an ankle sprain, we get injury to all of those structures. So what that can do is that can alter the afferent information going into the spinal cord, afferent information ending up in the cerebellum and cortex, and as a result, a change in efferent output. So when I'm thinking about constructing rehabilitation programs following a joint injury, what I'm thinking about is how do I integrate those 3 levels of central nervous system motor control? So how do I target spinal reflexes? How do I target the cerebellum? How do I target the pre-programmed task-specific motor control strategies that come from cortical level? So is there any evidence to show that individuals following an ankle sprain injury exhibit changes in central nervous system? Well, this was an interesting systematic review recently published by a Belgian group, and what they showed was that at cortical level and at cerebellar level, there are structural changes, there are functional changes, and there are connection changes. And they're some of the items that Dr. Grooms talked about earlier on. Is there any evidence then that the spinal reflex central nervous system processing is changed? And yes, there is. And what we see in individuals with chronic ankle instability is altered reflex stabilization of the ankle joint. So there's supporting evidence to show that there's changes at cortical level, changes at cerebellum level, and changes at spinal cord level. So the challenge for us as clinicians is then to determine how can we integrate exercises that challenge or that are specific or targeted towards those different levels of central nervous system control. And will targeting those different levels of central nervous system control actually result in more optimal outcomes? So if we think about the spinal level control, so to stimulate reflex stabilization, which we know emanates from the spinal cord, exercise should focus on subtle alterations in joint positioning that necessitate reflex activation. And one of the things, I'm fairly simple in terms of my clinical practices, is we are oftentimes trying to advance things too quickly, or trying to find, that interesting exercise. And it's important for us to go back to basics and actually do the basics at an exceptional level in order to have better optimal outcomes. So these are some exercises that I would utilize on a common time frame really, really early on in the rehabilitation process to make sure that I'm targeting spinal reflex stabilization. So they're classic wobble board exercise. Here we have a patient here. We have him on the rocker board, and we're just challenging sagittal plane reflex stabilization. Okay? And oftentimes, I think, us as clinicians, we don't want to utilize these fundamental basic exercises when in fact I think we should be placing a lot of emphasis on these types of exercises. And when we get a close-up here, we can see the reflex stabilization going on and in terms of the muscle activation. And remember that in order to stimulate reflex stabilization, you need fast perturbations. So again, we can see that clearly here in terms of the level of perturbation that's going on when he goes into single leg stance there. And then we'll challenge him in the frontal plane as well. So my thoughts around this are, don't overlook these types of exercises. I think they are really, really essential in the early phases of rehabilitation. And if we don't include these types of exercises as part of our rehabilitation processes, we're overlooking a fundamental component in the rehabilitation pathway, and that's to look at reflex stabilization of the ankle joint. Then, if we want to think about how might we target cerebellar level of control, so we can do this by performing balance and postural control exercises both with and without visual input. And one of the things that I like to use in the clinical scenario is the balance error scoring system. That was originally developed to test for postural balance after concussion. There is emerging evidence now to show that it can differentiate between ankle sprain groups and also between individuals with and without chronic ankle instability. And the most important thing about this test is we have an evaluation pathway for the actual test performance, and based upon the evaluation pathway of the test performance, we can then be specific in terms of what exercises as constituent components of the BEST can be used as part of our rehabilitation. But before you actually go to start to do postural balance exercises, I think this is something that is very much overlooked. Our research, we undertook a prospective study of individuals with first ever ankle sprain injuries. We assessed them within 2 weeks of injury, 6 months and 12 months. And at 12 months, we dichotomized them into those who developed chronic ankle instability and those who didn't. And what we used was the PCL model, so patient-oriented outcome measures, clinician-oriented outcome measures, and laboratory-oriented outcome measures. And one of an interesting finding was that we found that in the immediate phases post-injury, and then in the chronic phase post-injury, individuals with that ankle sprain had a reduced ankle strategy of postural balance. So if you don't have an efficient ankle strategy of postural balance, you move towards a much more inefficient hip strategy of postural control. And a hip strategy of postural control is characterized by frontal and transverse plane motions of the hip and frontal and transverse plane and sagittal plane motions of the trunk. So it's really, really important that before you start to implement postural balance exercises, that you ensure that individuals have a good ankle joint strategy. So what we term is trying to unfreeze the ankle joint. We see this hypomobility and rigidity across the talocrural joint and also across the midfoot. So we have to think about the functions of the foot. It needs to be a mobile adapter, and it also needs to be a rigid lever. So some of the common techniques that I would utilize for unfreezing ankle joint strategy would be your typical anterior to posterior mobilizations on the inferior tib-fib joint. We know that's an important joint because the anterior talofibular ligament takes its origin from the inferior part of the fibula. Also thinking about mobilizations applied to the talocrural joint. So here we have our typical Mulligan or our typical Maitland grade 3 or grade 4 mobilization anterior to posterior on the talocrural joint. Other things for us to think about are the articulations of the midfoot and forefoot and how we might include therapeutic processes for those joints that we might feel that are hypomobile. So thinking about the mobility of the cuboid bone. It's often a subluxation that we might find in common with an inversion ankle sprain trauma. And then also thinking about mobilizing the midfoot, again, to unfreeze and that ankle joint strategy of postural control. Things that you can do early phases, the likes of this exercise, where you're just getting the individual to explore triplanar motion at the foot and ankle joint complex. So you can see that's done in a nice controlled way, again, potentially getting them onto the BOSU and then doing that on an AirX. But if we move on then, in order to look at some postural balance exercises, here we have the eyes closed, double leg stance version of the BESS. And I'm just going to let these play through. We can see he's transitioning into the tandem stance position. We can count errors as part of that, looking at whether the foot is lifting off the support surface. We'll see him going into the single leg stance position. Okay, we can see lifting of the foot there, and we can actually see how challenging that is. And what we're trying to do again is to stimulate the cerebellum level of postural balance control. So moving then into the other best stances, we have the foam stance position in double leg stance, tandem stance, and we can see how challenging that is for him there. And in that scenario, he would be failing that test position. So failing in that test position means that that is actually too challenging for him as part of his rehabilitation at this single time point. And again, look at the number of errors that are being made in the single leg stance position. But often as clinicians, we overlook these basic exercises. But we need to be working from a strong foundation, from a central nervous system perspective, before we can integrate more challenging exercises. Here we can see we're doing something very simple. We're just causing an external perturbation in a single leg stance position. And that can be challenged in the frontal plane as well. Okay, so you can see that. But moving on then, this is the BESS. This might be a typical score. So 0 errors, 2 errors, 5 errors, 2 errors, 5 errors, 10 errors. So in this clinical scenario, this exercise, he's failing it. It's too challenging at this time point of the rehabilitation. So that's how we can utilize some of these evaluations to inform our clinical practices. So if we move forward, now we need to think about the cortical levels of control. So cortical pathways allow movements that are repeated and stored as central commands to be performed without conscious reference to consciousness. And this is a very interesting article. They used model-based image matching to reconstruct the skeletal biomechanics of inversion injuries. So we can see the high magnitude of inversion, the high magnitude of internal rotation. But if I move on here to look at the inversion, 0 represents the time when the foot hit the ground. Of most interest to me was the fact that in 4 out of the 5 cases, the ankle joint was or the rear foot was almost in 20 degrees of inversion upon contact. Now, if you have an inverted position of the rear foot upon contact, that increases the external inversion moment acting about the rear foot and heightens or increases your risk of sustaining an inversion trauma. So when it comes to thinking about how we stimulate cortical pathways at an early time point in our rehabilitation, one of my big emphasis would be to include exercises that emphasize hopping and landing. Okay? We have a positional error or a positional fault occurring upon landing in these individuals with chronic ankle instability, so we need to be able to train them how to land properly. So some of the exercises that I would typically use as part of that rehabilitation pathway are going to be shown here. So here we have our double leg pogos, and what we're doing is really to try and stimulate the intrafusal and extrafusal muscle fibers, and in particular the Golgi tendon organ. Here we can see a sequence of different drop landings. So going into a hop landing, Again, sticking the landing in a stable position for 3 to 5 seconds. Okay, so there's nothing complex about these types of exercises. It's just thinking about how do we target the 3 different levels of central nervous system motor control. So landing onto a BOSU, why do I do that? Well, we often see that contact mechanisms involve in basketball or volleyball landing on an opponent's foot. Okay, so again, just landing into a lateral position. And what we're also getting at is potentially replicating the injury mechanism. This is just working on foot placement. So these types of exercises certainly aren't beyond the capabilities of anybody here. But it's really just thinking about the different levels of central nervous system control. So when you are thinking about the reconstruction or the design of injury prevention programs or rehabilitation programs, perhaps we need to think about how do we specifically target spinal level, how do we specifically target the cerebellum, and how do we specifically target the cortical levels of motor control. So thanks for your attention, and I'd be delighted to field any questions.
Thank you, Eamonn, for your interesting presentation. Are there any questions from the audience?
Thank you for that
Jen.
presentation. It was great. Going back to what one of the other presenters said about challenging patients to what they can't do rather than what they can do, that it feels like there's a bit of a high risk with those ankles where you're challenging them and you're worried that they would turn their ankle in as part of that challenge. So would you ever tape them up so that you protect the ankle and then get them to do that challenge, or is that counterproductive?
Yeah, so particularly for people with pathological laxity and more for, let's say, rear foot laxity, so inversion laxity as opposed to anterior laxity. A technique that I commonly use would be called the subtalar sling technique. So basically you start under the 5th metatarsal, you come across the foot to, or under the base of the 1st metatarsal, you come across diagonally to the 1st metatarsal, you come up over the lateral malleolus and around the front. So it's quite a nice technique for someone who has that high degree of inversion laxity, and getting them actually performing the exercise with that mechanical restraint on can, increase. So it can increase their perception of stability. So when we're doing these exercises, there are a couple of things that I didn't mention. We'd always think about their pain response. We would think about 3 sort of psychological constructs. So how stable does their ankle feel? How confident are they in performing the exercise? And how assured are they that they're not going to sprain their ankle? So let's say we grade their exposure. Does your ankle feel stable? Yeah. Do you feel confident in performing this exercise to your expected ability? Yes. Do you feel assured that you're not going to sprain your ankle? No, that was a pretty vulnerable position for me. So what you do then is utilize that to step back to the exercise that might have been prior to that type of exposure. Yeah, thanks.
There are some more questions from Slido.
Great.
So usually taping is used also for getting people back to sports environment. Yep. So for how long do you recommend taping?
Yeah. So there was this kind of, in what we call in Ireland, an old housewives' tale, that basically if you brace or if you tape, it's going to lead to further impairments. That's absolutely not the case. We know through some randomized controlled trials with big numbers, so 1,000 participants in each, that ankle joint bracing is actually better than ankle joint taping. So, and it's particularly more effective for individuals who have had a history of previous ankle joint injuries. So we know that bracing will reduce your risk of sustaining future injuries. Again, it comes back to athlete choice and athlete preference. You know, one athlete might be comfortable with using a brace, or another athlete might be more comfortable with using taping. So you've got to have a number of different braces in your clinical scenario or your clinical armory to actually have the patient utilize those different braces, get the feedback from them, what is the most comfortable brace for them to use. Do they feel confident that they can perform their sports activities to their desired level? Yes. Do they feel stable in that brace? And do they feel reassured that they're not going to sprain their ankle in that scenario? Taping, it's purported to loosen following exposure to fatiguing exercise. Some research says yes, some research says no. So again, it's just a consultation with your athlete. And again, I would encourage you to think about those three constructs. How stable does the ankle feel? How confident are you performing the task? And how reassured are you that you're not likely to sprain your ankle joint?
So thank you for your answers, because time is running. We will skip. We have a lot of more questions, but we won't have time to go through every of those questions.
Thanks, Katrin.
So
Thanks,
thank you,
Nicolas.
Ola.